At this point, I would say that there really is not a great understanding of a mechanism of action for how and why patients and their tumors become resistant to antiangiogenic agents. That really still needs to be elucidated. One of the things that is also being looked at is the potential benefit of continuing an antiangiogenic agent beyond progression, and whether patients do better even if they've demonstrated progression by continuing on the antiangiogenic agent and perhaps switching out the chemotherapy given with it. So this is, at this point, a study of clinical inquiry. It is the subject of some studies, but it's not widely practiced at this point, and I would say it's just an open question right now, and a provocative one with some hints from retrospective work that patients may benefit by continuing an antiangiogenic agent beyond the point of progression and keeping that going while changing out the agents given with it. There are several different agents that can work by antiangiogenic mechanisms. There are monoclonal antibodies, there are oral VEGF inhibitors, and we need to do more to evaluate the potential benefit of sequencing these. What we can say is that in the REVEL trial that looked at ramucirumab in combination with docetaxel, after patients had already received first-line chemo-based treatment, the subset who had received bevacizumab, another antiangiogenic agent, still received the same relative benefit with the addition of ramucirumab as the broader population, suggesting that there is not so much cross-resistance that you can't potentially benefit from sequencing of one antiangiogenic agent to another. The fact that there are other antiangiogenic agents, including oral VEGF inhibitors, leaves that option open as well, but really needs to be studied further. So there are studies that are beginning to look at this, and I look forward to seeing clinical data to help guide my decisions and potentially lead to an approval of an agent in the future for this. Right now, it's still an open question. We don't know yet whether antiangiogenic agents in combination with immunotherapy will lead to a significant improvement in clinical outcomes. Preclinical data suggest that could be a fruitful approach, and what we have seen actually comes from the Empower 150 trial, which looks at a chemo backbone of carbo and paclitaxel with bevacizumab, and then with or without atezolizumab. And what we've seen is a significant improvement in the arm that got atezolizumab. And we've also seen in this trial alone a benefit with the subset of patients with an EGFR mutation or ALK rearrangement. What we don't know yet is whether that is specific for the chemo regimen, which I doubt, the checkpoint inhibitor maybe, or potentially some particularly effective role for the combination of an antiangiogenic agent with immunotherapy. We need to study this much more. We really haven't got any trials that have directly tested this. But that would be very attractive, I would say, because one of the challenges with trials combining immunotherapy and chemo is that while the efficacy is good, we don't know if it's clearly better than everyone getting a sequential approach. And one of the hopes and promises of immunotherapy initially was that we could be able to avoid the chemotherapy side effects and practical challenges of administering that for months to years in patients who could benefit. So if we could improve the clinical outcomes and the range of patients who benefit from immunotherapy by giving an antiangiogenic in combination with immunotherapy, we could achieve that clinical benefit and still be able to avoid chemotherapy for the patients who don't necessarily need it. Preclinical data have demonstrated that the EGFR mutation and potentially ALK rearrangement is associated with a greater sensitivity or delay of resistance if these targeted agents against that driver is administered with antiangiogenic therapy. We've seen also clinical data in the EGFR mutation setting that really has fairly consistently shown a benefit in terms of progression-free survival and some suggestions of modest improvement in overall survival when anti-angiogenic agents are administered concurrent with an EGFR inhibitor. We haven't seen as much with ALK rearrangements, but a lot of times we've seen that the patterns we see with EGFR apply to ALK and vice versa. And it will be extremely valuable to see a clinical trial result that addresses this question of a combination of an anti-angiogenic agent in combination with a very effective ALK inhibitor.